We have our next speaker, Dr. Manisha, who is Professor of Ophthalmology in Medical College, Rohtak, and she will be talking on managing coexisting cataract and diabetic macular edema.
So it's a double trouble when we have cataract surgery along with diabetic retinopathy. So we cannot escape. We need to know the nuances, and we have to manage effectively with the aim of good visual outcome any case of cataract surgery with diabetic retinopathy. Trouble is actually manifold. Trouble is specific to the cataract surgery. It could be rigid pupil along with autonomic neuropathies or glycogen deposition. There can be increased reaction to surgery. Inflammations are always more with diabetic retinopathy. Neovascularization of iris could be there. Zonular instability is definitely there in advanced cases, and the type of cataract also. In my experience, I think it's thicker, harder cataracts along with diabetic retinopathy. So troubles secondary to systemic effects are there. There could be glaucoma, vulnerability for infection, and additional comorbidities. And the master trouble is acceleration of diabetic retinopathy. So why it's important to know? Globally, we know that cataract is the leading cause of blindness, and a lot of people are getting affected, and it's going to be a tsunami after many years from now, about a decade or 2 decades, I can say. Overall, it is estimated that up to 20% of all cataract surgeries, they are performed in diabetic patients overall. The first step is we should explain the pathology and the visual prognosis to the patient. Needs a lifelong follow-up, and the patient should be ready for repeated interventions, and detailed consent is always required. So it's an opportunity for us to counsel about diabetes to the patient when he comes with cataract to us. So what are the pre-op considerations? Systemic, we need to have a good glycemic control, assess for any systemic effects, nephropathies, cardiomyopathies, and so on and so forth. And ocular, we have to see for myomitis, blepharitis, recurrent erosions if they are there. We need to control them first. And keratometry also varies. So when the eye is stable and the cornea is fine, we should do keratometry. Glaucoma can be there, cataract surgery or combined surgery can be planned. We need to know the status of the pupil, cornea for neovascularization of iris. Need to grade the cataract. LOX grading can be done, and gonioscopy for high-risk PDR if it is there. Fundus photography, autofluorescence, fluorescent angiography has to be carried out. OCT and OCTA, and also ultrasound is important. So diabetics have much higher inflammatory mediators, we all know, interleukin 2, 10, 12, interferons, tumor necrosis factor, VEGFs. So pre-op NSAIDs should be given. 1 week pre-op napafenib, bromfenib or ketorolac needs to be given and should be continued for 4 to 8 weeks post-operatively. And if the patient is a glaucoma patient, we have to stop the prostaglandin analogs 2 weeks prior to surgery. And what are the intraoperative considerations? Pupil management. Preoperatively, good pre-op preparation has to be made for the patient, and YAG laser mydriasis needs to be done. Intraoperatively, aniline, avoid iris touch, chafing, pupil expanders can be used, as it was shown by Dr. Ashish. So we can do pupillary stretching, multiple sphincterotomies can be done, retractors can be used, and other devices which can expand the pupil should be used. So phacoemulsification should be the choice. And what are the tips we should take care while there is a diabetic retinopathy in cases of cataract? We need to do careful biometry, especially in silicon-filled eyes. Rexis has to be, minimum should be 5.5 millimeters. There should not be any capsular phimosis, anterior or posterior capsular opacifications. Good viscoelastics for endothelial protection should be used. Gentle hydrodissection is required because we know that the zonules are always weak. Complete cortical cleaning is must. No PCO is required, should not be there. Thorough capsular polishing, and in the bag IOL positioning has to be made, and suturing of the main wound if required, and we need to meticulously remove the visco once the surgery is over and nucleus is out, clean the visco properly. What are the choice of IOLs we can make? We have to consider large diameter IOLs single piece PMMAs, surface modified heparin coated or fluorinated lenses, and we should avoid silicone foldable IOLs. Multifocal IOLs should be avoided. Contrast sensitivity is reduced in such cases. AC IOLs and RS fixated IOLs also should be removed. It should be avoided. Worsening of the pre-existing diabetic retinopathy, and there is an increased rate of retinopathy progression and worsening visual acuity in eyes undergoing cataract surgery compared to unoperated fellow eyes in people with diabetes. We all know ETDR says that, and Deniston et al. They said that significant post-operative progression of center involving diabetic macular edema occurs after cataract surgery. So perioperative intravitreal steroids and anti-VEGF agents are a good option. So worsening of diabetic macular edema was seen in a patient. There was a 56-year-old female with diabetes for last 15 years and with poor control. The vision was 6/18 and was under good diabetes mellitus control. Anti-VEGFs were given. The patient was lost to follow-up for 1 year. The best corrected visual acuity as the patient comes is 636 on a follow-up, pseudo-faking, and now the patient is unsatisfactory and unhappy because of the edema. So this was the picture. You can see that the edema, it increased with time, and later on anti-VEGFs were tried and this all subsided, and we had a normal macula later on. So PDR, proliferative diabetic retinopathy, patients with pre-existing untreated PDRs, they are likely to progress and develop vitreous hemorrhage and other retinal complications. PRP is recommended preoperatively in PDRs. When the cataract is dense and prevents preoperative PRP, two options are there. Indirect PRP immediately following the cataract procedure should be carried out. Plan and perform within a week after cataract surgery. Cases with dense vitreous hemorrhage or for eyes with posterior polar tractional detachment, combined surgery with vitrectomy and endolaser photocoagulation should be carried out. So cataract surgery and intravitreal injection of intravitreal steroids can be planned simultaneously with cataract surgery. Diabetic macular edema with ERMs or tractional component, particularly if the patient has not been treated previously, plan the intravitreal steroids. It can be done during cataract surgery also. We can do ILM peeling in eyes with persistent diabetic macular edema. It's beneficial. Post-op care, suppress the inflammation. Glaucoma has to be controlled if it's there. Avoid early YAC cap. Keep the pupil mobile. Evaluate and treat diabetic retinopathy early before the PCO develops. Refer before there is acceleration of diabetic retinopathy. VR surgery can be done after 1 to 2 weeks. And laser PRP can be started on day 1. So the conclusion is, depending on the degree of diabetic retinopathy, individuals with visual significant cataract, they present special obstacles during surgery and subsequent rehabilitation. With appropriate treatment, such patients can achieve excellent vision. Anticipate the trouble and do a meticulous pre-op workup. Perform early cataract surgery and treat DR. Be on a lookout for any worsening of DR and manage on standard lines. Thank you.
Very comprehensive and excellent presentation, ma'am. And I think this is probably out of all the situations we discussed in this session, this is probably most commonly seen in our practices. And I would see it in like two set of scenarios. One is a DR patient being treated regularly and now he or she develops a cataract. And second scenario is patient who is seeking an opinion for cataract is found to have both a treatable center involving DME and a treatable cataract.
Yes.
So approach I think to both of them will be little different. For a patient who knows everything about DR and getting treated for DME regularly, he probably needs to be counseled about the visual gains he can expect, and also that need to continue DME treatment for long term. And probably most of us would operate them at the time when macula is dry, because he's already on injections, so
That's
he understands
important,
the concept. But this patient, which is a treatment naive patient, and he came for cataract and now he is found to have DME, we need to spend much more time on him, and we have to, main issue what we face in our practice is to to tell them and guide them which is the core issue. Sometimes they are so much focused on IOLs and cataracts, they are ignoring the fact that they also have a sight threatening disease. So I think that's a very important part of our counseling, and rest of the things you very
Yeah,
well
yeah.
I think explained how do we address.
There's one third scenario wherein the patient comes with diesel vision because of wide diameter damage, and when you see, you feel that you are not able to do laser because the cataract is more dense. So what I do in these patients is that I ask the patient, I just give a sugar injection to a cataract surgery that gives me a month's time so wherein I think my basic aim is that before that I should not be late in therapy. We should not develop a neovascular vision or something like that. So what I do is I do an injection to a cataract surgery. There is that after a month we do the laser once the damage.
Then we need to do ultrasound in all the advanced cases of cataract, yes. Yeah. Yes, yeah. Thank you so much. And I would like to thank Dr. Partha for giving us this opportunity. It was a very well invited session, and all the speakers. I thank sir on behalf of everyone out here. Thank you so much. Yeah.